Hello, dear Andra and friends in Riga. It is my pleasure to speak to your 30th anniversary celebration, and I congratulate you and thank you for the kind invitation. The topic of my talk is how to integrate and promote functioning, fitness, fun, family, friends, and future into therapy. I will cover three main topics. The first two are quite closely related. I want to share some thoughts about what we understand by childhood onset disabilities, and then go over the aspects of child development and how this understanding of child development informs our therapeutic approaches over the last 30 or 50 years. And then some comments about the concrete examples of how this influences therapy and the daily life of the child and the family. So if we think about rehabilitation, and often our field in developmental pediatrics or pediatric rehabilitation is also called rehabilitation, I put here two pictures of two people who have very similar struggles. One is an elderly, bit overweight male who most likely suffered a stroke and is receiving supports and therapy in his rehabilitation program. And on the other side, you see a young kid who was born with cerebral palsy and also uses crutches and has some assistive devices as well, and is also receiving therapy. The difference between these two are more than just the difference of age. There's a difference of maturity of their brains. There's a difference of different health conditions that they might have. There are differences in how much they still are going to grow. The child will obviously grow while the elderly man stopped growing for a long time. There are differences related to their memories and how they recall aspects in the past. The adult person probably will recall how he was able to walk, how he was able to play soccer or run or jump. The child does not have any of these memories because that was never something that he was able to do. And they also have probably quite different plans in their lives. One about his retirement and seeing grandchildren maybe, and the child about growing up, finding a partner, learning a profession, becoming more independent, and so on. So the development of both of these people is very different. And the approaches to their therapy and support should also be quite different. So we should differentiate between what is rehabilitation to bring somebody back to certain abilities that they had before a stroke or any injury happened, and habilitation, which is developing skills in children that they never had before within their abilities, depending on the injuries or impairments they suffered around the time of birth. So thinking about these differences, it is important to understand a bit better what do we know about the development of the brain of a child and how this development allows a child to acquire certain skills. And we had several theories of development, and I will go over those very briefly only. The oldest theories are the maturation theories, where we discussed or observed certain things in children when they were very young, especially reflexes that they presented. And then we observed that after reducing certain reflexes, they developed voluntary movements. We also observed that it seemed that children developed certain skills according to certain stages in certain sequences. And therapy approaches based on these observations tried initially to inhibit pathological reflexes that were considered not appropriate for a certain age of a child, and promote the development of the right sequence of development through a variety of approaches and early stimulation. This is a video I like to show to demonstrate how observing something happening in a certain timely fashion or one aspect after the other does not necessarily mean that one thing depends on the other. It is not this young, strong man, although he is strong, that is pushing the subway forward. It is an observation, and similarly, certain observations can lead to wrong conclusions. After the, and still related to the maturation theory, I want to show you another example that's not from the animal world, that's from the vegetal work, from plants. What you see in this picture here is called Biosphere 2. It was built between the late 80s, early 90s in Arizona. And it's part of a project to simulate an Earth environment in a closed system in order to explore what is necessary for human beings and nature to develop, for example, in another planet. And we hear a lot about civilizing Mars and so on. So one thing that they did in this biosphere was to plant trees. And the conditions were perfect. They had the right amount of sunshine, the right amount of water, perfect soil with all the nutrients, added fertilizer to that. And the trees grew quite well for a while. And then suddenly, after a certain size, they all would fall over and die. What was happening? These trees were all within an enclosed, protected environment without any wind. Without wind, the trees were not able to strengthen their roots and be able to anchor themselves stronger in the soil, and that made them weak and unable to thrive. So another idea how sometimes we think about knowing all the details that we know about maturation and a process, and then we forget some other aspects in this example, some aspects that were outside of the tree that was necessary, an environmental factor that was necessary for these trees to develop. The next type of theories that we can relate to are called dynamic systems theory. These specifically applying towards movement disorders propose that the movement surges from the interaction of different systems. So we have the body as a system, and we have the environment as a system, and this body or the person that has that body wants to develop some task or execute some task in that environment, and the interaction between these different systems then leads to something that you can observe as a whole movement. An example of a system approach, a dynamic system, is the murmuration of birds. You see groups of starlings flying around. This is one movement composed by many different individual movements, but they all react to any other elements from the outside, from the environment, from the neighboring starling, from the neighboring bird. And in that way, you create a big system that is moving overall, like many tiny body parts, muscles, elements, plus input from the environment will lead to a movement of a whole body. The third and a more recent theory, although also about more than 20 years old, is the neuronal group selection theory. This is a theory that integrates previous theories. It concedes that there are innate motor patterns that allow for some active volitional movements, but it also describes that these initial movements are highly variable, and thus this variability of movements, like you have a whole menu of different movements and activities that you can perform, and in certain contexts will lead to the brain to select the best and most efficient neural groups for specific movements that allow to execute the task. So that's where the dynamic systems theory comes in. So the therapy in these, from this perspective, aims to promote the autonomy, promote variability of experiences and opportunities to practice and repeat, so that the most efficient neural groups become stronger and the person can develop the skills that they find are important for them. I have here 2 videos that will be showing some of the variability that I was just commenting to and the impact of environmental factors. So you see different patterns of crawling or moving around, commando crawl here. On the right video, you see repeated this little child managing a staircase in a very unusual manner, but very effective. She wants to go down, she doesn't want to hurt herself, and she manages that. And on the left side, you see now a child on a very slippery floor here as well, that does not allow quite well to be able to be on their knees or feet, and that's how they manage. And here now they have a baby that is on grass. And I remember my own son, when he started crawling, he was naked on the grass, and the grass was not something he really liked. And whoops, his tummy went up and he was on his floor. So environmental factors, different abilities to make a movement complement each other so that people develop the best fit and the best pattern of movement for the task that they want to pursue. When we think about these variabilities, we need also to remember that a lot of what we learned about the development is deducted from large groups of children. So that leads to certain trajectories that we all have learned how a child develops different motor skills in a certain sequence. But it is important also to analyze that if you look one child, one patient, there are very different individual trajectories. And this is a nice study from colleagues out of Thailand that followed children in the first year of life. And you see the various trajectories according to the aborted infant motor skill percentile, where these children were developing over the months. In that study, they also analyzed the impact of certain contextual environmental factors. In this case, it was a hammock and a chair, which in Canada is not allowed anymore to sell. I'm not sure how that is in Latvia. And they concluded that the children that were offered this type of chair were actually developing slower, besides all the other risks that these chairs have, and concluded that it is not recommended, while the hammock seemed to be beneficial for children as a more, allowing probably more variability of movements for the child inside the hammock. So we need to look at the individual elements as well, and not use what we have known and learned from a group setting to make this an expectation and a goal for anything that we do in our therapies. We need to look into each individual child when we want to identify what would be a useful and meaningful goal for this individual child when we select therapies. So I will move over now to a bit more conceptual aspects. How do we choose these goals, and how do we define appropriate therapies, outcomes, approaches, and so on? And here's a quote from Pablo Picasso that I find quite fitting also for our field, although we are not painters, but it says, "Learn the rules like a pro, so you can break them like an artist." And here you see a picture that he drew called Science and Caring. And you see he dominated all the rules of a good painter with illumination and so on. And these would be, I'm on the right, I put some rules how we were trained and which still are important to know. But not all of them are important for developmental pediatrics or habilitation of children with impairments. So one rule we learned is health is a complete state of physical, mental, and social well-being. We also learned that a diagnosis is necessary because the diagnosis defines the therapy. Without a diagnosis, no therapy. We learned that the doctors are the ones who make the diagnosis, and therefore they are the ones who prescribe the therapy. And the therapists follow what the doctor's orders are and treat according to the prescription of doctors. As I showed before, we learned that development is a linear progression that goes according to predetermined stages. And we have been trained that patients have to be patient. That's the meaning of the actual word. Now, when we think about health, the first rule that I put here, the definition of the World Health Organization, there are new concepts that have been proposed and that I find are more fitting for the work that we do. Huber and different authors defined health as the ability to adapt and self-manage in the face of adverse physical, mental, and social circumstances. They argue that the utopic definition of health from the WHO is inachievable for any human being and therefore not really helpful when we try to promote health and support people in living healthy lives. They also provide a definition of functioning, and that's how I also agree with that, is that functioning, regardless of the degree of impairment, like how you function in your daily activities, that is evidence of health. If you're able to do the things that are important for you and that you want to do, then you are healthy. I usually use glasses. I don't need glasses here at the computer. That makes me able to drive and to go around. Functioning is also being proposed, and you'll see the references down on the slide by Bickenbach and others, that it should be the third indicator of health besides morbidity and mortality. If we only capture data and statistics about how many people have COVID or how many people died of COVID, it doesn't tell us how people that have COVID or that had COVID in the past are actually doing. How are they functioning? What are the issues that they're encountering? So functioning needs to become an indicator of health. The other aspect that I mentioned from the rules is the aspect of diagnosis. What does it actually mean to make a diagnosis? The meaning of the word is loosely translated, the ability to tell apart. Dia or dia is separate and gnosis is knowledge. So knowing the differences or knowing what is what, recognizing something. It depends on the gathering of information and facts. So we take a history, we do a physical exam, we have different test results, and we generate a hypothesis. We see something, okay, this looks like a certain condition. This might be cerebral palsy. This might be some type of autistic disorder, and so on. And we rule out all the other elements that might be confusing us until we find the best explanation for that. And I like to compare that with creating a sculpture, or as Michelangelo said when he was asked how he sculptured David. So, well, I saw the angel, he sculptured the angel, and he said, I saw the angel and I chipped away everything that was not part of the angel. And diagnosing is like hammering off the pieces of a rock to create a sculpture. Now, when we talk about functioning and functioning being an important aspect of health and an evidence of health, how do we describe functioning? And functioning is more than one aspect. Functioning is a whole profile. There are lots of elements that compose functioning. So we also collect data, but with the purpose to aggregating them. How are they related with each other? How do they influence each other? It is a process of analysis of systemic interactions in that way. And it depends on the validation by the patient. So any interpretation that we make about functioning, the patient needs to agree with us. Yeah, that's really what I want to do. That's really important for me. Or that's how I do it. That's how I move around. That's how I express myself. And it also depends on the collaboration of a whole team, because not one person is able to capture all the aspects of functioning that are relevant for one person. So creating a function profile is like putting together the pieces of a mosaic. And why is a function profile important for the patients that we describe? And from this paper here out of Australia, that is more about the National Disability Insurance Scheme, there is a description of complexity and how difficult it is to find best supports for children, for people in general that have very complex conditions, in this case, intellectual disabilities. And they describe that complexity always arises at the intersection between an individual and her or his environment. That's what it makes it extremely complex. We have obviously complexity within medicine, within complex health conditions that require multiple treatments, medications, therapies, and so on. But that person interacting with an environment makes it even more complex, because there are different environments, different factors, and people with the same diagnosis, with the same medications, with the same treatment plan will respond very differently in different environments. So that's why you need really to have this integrated view. And here is another picture of Pablo Picasso when he broke the rules, the picture called Guernica. And this picture, it was not important for him to depict an exact description of a patient, a nurse, a doctor, but to express the horror, the pain, the panic of war. And he decided that it was better to do it this way than in a nice picture. So one can see the despair of the people and animals described there, depicted there. So one thing that we need to get rid of is what I call linear thinking. And this is the linear thinking as it explains our traditional medical view of how illness happens. We have a cell, and the cell is damaged by any etiology, a toxin, a genetic disorder, lack of oxygen, whatever you can imagine. And this leads to damage of the tissue of which the cell is part, and impair somehow the function of this organ, and the body of this person then presents with symptoms that we can diagnose and define an illness. Then, based on that diagnosis, we choose the appropriate therapy, and giving the therapy, most of them act directly on the cell. And the result of that is that these negative impacts disappear, the illness disappears, the patient is cured, and we have health. If we don't have a therapy, then we simply call that, okay, that's a person with disability. We cannot cure it. There was some damage. There's an illness, there's a diagnosis, but we cannot cure it also, so let's call it disability. That's linear thinking. In linear thinking, we have the impairment, that's the aspect of the body, and we linearly conclude this impairment leads to a disability, so something that a person cannot do anymore, and this disability in society is described as a handicap, so this person with a handicap cannot participate anymore in different activities, and that's it. And that was the basis of the ICIDH in '89. Impairments are lesions at the level of body functions and structures. The inability to participate is basically what disability describes in the previous linear thinking element, and handicap is what happens when you are in an environment that is not suitable for you. In the ICF, we have these elements from the linear thinking, but we now have bidirectional errors. And we have a person with a health condition that presents with certain impairments, has certain limitations of activities, restrictions in their participation, in consideration of their personal factors and the environment in which they are living. So in this systemic thinking approach, the functioning of a person can be different depending on the environment. A child can function differently at school and at home, as we all know. And it allows us to identify better where can we intervene in order to improve the functioning of that child. So the therapeutic approaches, we can define them and differentiate them between acute care and developmental care. Maybe that's an easier way to understand where habilitation activities are situated, which I call developmental care, and which acute care activities are seen. And both of them are obviously necessary and important, but they have different strategies. In the acute care setting, the strategy is curative to eliminate the cause. That is the initial description that I showed you, where the cell is damaged and we try to reverse that process and generate a healthy person. In the developmental care situation, we strive to optimize the functioning of the person. It's a biopsychosocial concept. It's not curative. We try to get to the best possible situation for this individual person. And these are fluent interactions. So sometimes you need more acute care strategies, and sometimes you need more the developmental care strategies. The patients are seen quite differently in different settings. In the acute care setting, the patient is passive. The patient is compliant. If you think about an emergency room, about somebody needing to be intubated, they're completely passive. They are being treated by others. But in the developmental care, for you to understand what is important to that child, what is important to that family, what do they value in their life, they need to be active, they need to be empowered to let you know that, because that will determine your approaches and your therapies and your supports. And it also has a difference how health professionals behave and relate to each other. In a very acute care setting, there's a very stringent hierarchy, and that is necessary. You cannot lose time in discussions that take on forever. The patient might die until you found the right idea. So it is effective to have somebody who gives the orders, who prescribes, who moves quickly and is quite experienced in doing that to save lives. In developmental care, we often do not need that urgency. It is more important that health professions are seen as counselors, as people that can give ideas, can give suggestions, accompany a family, and are part of the team where the family is also part of that team. We can also describe these two aspects with the words carpenter and gardener. And I came to this idea through a book that I just read recently, which is called The Gardener and the Carpenter by Alison Gopnik. It is written for understanding the relationships between children and their parents, but I think it is also very relevant to the type of work that we do. The gardener metaphor that she uses means that when we raise children and when children grow up, we have been kind of trained like a carpenter, that we need to know exactly what are the best books to read to a child, what are the most appropriate toys to buy for them, what are the best courses to give to them. And doing everything right, we will have a successful and healthy and happy child. While the gardener is more like, okay, we try to do the best in having a good soil, remember of the biosphere, we put in the right amount of water and nutrients. But what comes out at the end is not so predictable. You might have wonderful new plants that come up. You might have some weeds that will grow. You might have bad weather in the meantime. You might have, so it is not that straightforward. And that's how I feel that sometimes therapists are more the enablers of an environment that allows a child to thrive, allows a family to thrive with a child that has an impairment, and find their way that best suits them, instead of being prescriptive and saying you need to do this and so many times per day and so many times per week. And if you do all this correctly, then your child will do this and that when they are growing up. So that is a bit the analogy that I see here. This leads us to, how do we do that? How do we provide an environment that is possible for somebody to thrive? And we have, and you are aware of that, and I want to say thank you, so apologies to one of your colleagues who translated these F words in childhood development, as we call them now, which was an attempt to describe the aspects that are part of the ICF in that systemic view in an accessible way, both for children and for families, to understand these are different aspects that are important in your life, and that's what we want to focus on. So this paper was published over 10 years ago and has been downloaded thousands of times, is being presented, is being translated in many countries, so now also for Latvia. I'm very pleased with that. And I want to share some ideas about the use of the F words in the following slides. Yeah, here are the different languages which it has been translated. What we feel is useful in having the F words is that the F words allow you a variety of what we call entry points to therapy. So you have the aspect of fitness, of functioning, of friends, family, fun. And all these are important. Sometimes one is more important than the others. Sometimes only one is important. Sometimes two or three are important. It doesn't really matter, but it gives you the ability to discuss things with a child, with a family, to understand how is their life like, and where would they like to accomplish changes to develop something new and something important for them. So you can have these points of entries, and you don't have to go in the sequence as it is said here. You don't need to start always with fitness and then think about functioning and then think about making friends and then consider also the family and maybe have some fun. You can turn this around as you like, and any aspects that you want to start with is okay and is appropriate. So you can, for example, find an activity that is really fun for the child, and as a side effect, you will have improvement in fitness. For example, a child that likes to be in the water, if they have an opportunity to be in a swimming environment or in water environment, they might increase their cardiorespiratory resistance and so on. On the other hand, we also know that, and this is the paper I put in here by Virginia Wright and colleagues, that if you just focus on the fitness aspect or body functions, for example, treating patients with Botox, it doesn't translate immediately in change in activities and participation, that there is a mismatch. So you need to have, it's not that wrong in using Botox, but you need to know why and for what you're using it, what you want to accomplish. And then it might make more sense and be more effective. To do all that, you need teams that can collaborate with each other. And what I like to propose always to people is that you become transdisciplinary in your teams. So we have these definitions of unidisciplinary, you have one discipline, multidisciplinary. You have two disciplines involved, but it's like I see an orthopedist and I see an ophthalmologist, but they do not really talk to each other because they do different things. And you have interdisciplinary people where they overlap and they consult to each other and inform each other. But then the transdisciplinary service is a bit more than that. It is really learning from each other and acquiring the knowledge that each other have. So if you think about a physiotherapist and a speech and language therapist, they can learn from each other. They can learn about posture and articulation. They can learn about different aspects that can be integrated in their therapies that are important for the other therapy. So it is something that can happen in a more in a team that is working together for a long time. So you need to have people that can collaborate well. They need to know each other well. They need to trust each other and be open to sharing their knowledge with the other professions and also learning from the other professions. This improves the quality of the overall treatment and makes it easier for families to understand and to feel that everybody's on the same page and everybody's working on the same goals. Based on the efforts, parents initially approached us and developed different tools. So this was the first here, the efforts agreement. That was a mother in the United Kingdom, Diane Kay, and she used that to share with therapists and teachers how she would like them to interact with their child and with them as a family. Functioning, I want to do stuff. It may not matter if I don't do it like everyone else, like being tolerant for that. Family, they know me best and I trust them to do what's best for me. Listen to them, talk to them, hear them, respect them. Fitness, everyone needs to stay fit and healthy, and I'm no different. I might need to use different ways of getting fit and staying fit. I need help to do this. Fun, whatever floats my boat. Friends to meet, get to know, have fun with, to learn with, to grow old with. And future, the future is now. Tomorrow is what I make of today. I don't want opportunities to pass me by. Help me achieve what I can today. Thank you. And then we have here the efforts profile where children can put in or with pictures or with words, descriptions of their profile. What are my strengths, for example, how I do stuff, who is my family, what I do to stay fit, what are things that I like to do, who are my friends, and what are my goals for the future. And this is a similar collage here where you can also put in the elements like on the profile here. And then we developed some goal-setting instruments. And this here is the goal-setting instrument based on the F words, which was adapted from another instrument, adding the aspects, what do we want to do in this different area and why? And this led me to a reflection on the Golden Circle by Simon Sinek. You might have seen this already. It's not so new, but I think it's very fitting as well. He made it for business decisions and entrepreneurship. But if you think about therapy interactions and interactions with families, I find it very important as well. So it's called Start with Why. And the concept is basically that usually the first thing that we ask families is, what do you want? What is your goal? And parents might answer, oh, I want my child to walk, or I want my child to talk. And then we often then go to the how. Okay, we can, if you want work on walking, we can offer you some treadmill training, or we can offer you certain types of therapies, or we can offer you a group activity. And the why is actually the most important question. Why do you want that? And there might be a very different consequence depending on the why. So I want my child to walk, maybe to be together with other children. So it is, okay, you want mobility for social interaction. That's the why. Or you want your child to talk. Why? Because I feel that it is difficult for her to express when her emotions are not, when she's happy or when she's angry or whatever. So that's the why. And then once you have settled on the why, then can you elaborate, okay, there are different ways how we can approach that. So it can be with technology, it can be with certain therapies, it can be with certain settings that are available to attend activities for children, inclusive activities for children where they can see other children and model things. So it makes a whole different, the story, it changes the whole story, how you see therapy and what it is for. So this video is really interesting to watch. Another tool that was developed by CanChild is the About My Child, and this is a tool that is somehow based on the F word. So it starts with a strength-based approach, like talk about the family, about fun, and what does your child like to do. And it also collects certain aspects of concerns from the parents according to the chapters of the ICF in activities and participation. This is a tool that has now been adopted in our province of Ontario for the coordination of services, which is called the Smart Start Hubs. And you can see here I highlighted it. So this Smart Start Hubs will focus on the child and family strength and not on the deficits, and will use the approach to promote child and families' well-being based on the efforts for child development. So that's a nice example of impact of research into policy, how things are being changed and some rules are being broken. Summarizing, I want to conclude with, I hope I could show you that it is important to understand that children with impairments require care with a developmental perspective and not a rehabilitative perspective, that to promote development, therapeutic teams should adopt a systemic view and collaborate in a transdisciplinary way. And to be effective, therapy needs to be embedded in the daily life and attend the interests of the child and family. The efforts can help to identify these most relevant points of entry to decide about therapies, and that there is no rehabilitation without inclusion. To finalize, I want to share a video about the efforts with you, and thank you very much.
The F words in childhood disability, they all start with the letter F, and they mean a lot to me. They are related to the International Classification of Functioning, Disability, and Health, or ICF, from the World Health Organization. Please pay attention to these words when we spend time together at home, school, or during therapy sessions. These 6 words can help everyone understand what really matters to me. Some people are so focused on my disability that they forget that I want to grow up to be healthy and happy like everyone else. Here are my favorite words. Function. I want to do things. I don't care if I do them differently from other people. Let me figure out how to do things on my own. It's okay if I need extra time and practice to find a way that works for me. Family. My family knows me better than anyone else, and I believe they do what's best for me. Always listen to what they have to say. It's important that you talk to them, learn from them, and trust them. Fitness. I need to take good care of my body, especially while I grow. Please help me find ways to stay healthy and active. Moving and exercising are the best ways for me to find out what my body can do, which makes everything much easier for me. Friends. I need to have fun, learn, and grow surrounded by friends. I can learn from them, and they can learn from me. It helps all of us get to know each other better. It's so important that I have the chance to build strong friendships. Fun. I love this tiny word. I can have fun while I grow learn, and have a blast. Can you help me discover what things might be fun for me? And can we find ways to have fun together? Future. The future is now. What happens tomorrow depends on what I do today. I don't want to let opportunities pass me by. Ask me and my family to dream of a future that is possible, and don't tell us what is impossible. Now that you know my 6 favorite words, please help me put them to good use every day. Are you with me?
So here's our contact information. And once more, thank you very much for this kind invitation. And I wish you all the best for the future of your center. Thank you.